Okay, in this video, we're going to be discussing and going more into depth with ARDS and what that is and how it affects our body. So, ARDS is a life threatening, severe lung condition categorized by widespread inflammation, fluid leakage into our sacs, our alveoli, and the stiff lungs, causing low blood oxygen levels. Our etiology and etiology just kind of means um, a study of the cases or reasons behind a disease and like why they happen. So, one of the big impacts and reasons why ARDS can happen is a direct lung injury. Um, and those can be like pneumonia, and pneumonia can be either bacterial or viral, COVID-19 or influenza, or even a fungal. Aspiration of gastric content, that just means like the patient either aspirated or was like throwing up, and then all those like acids went into their lungs, which causes a lot of damage in the lung tissue and in the alveoli. Near drowning, obviously they're inhaling and aspirating water. Um, Toxic inhalation, they've been in a smoke, in a fire, they've been around a lot of smoke and inhaled a lot of carbon monoxide that will affect them. And then pulmonary contusion, which is just severe trauma to the chest. The indirect lung injury, that's sepsis. That's one of the leading causes of ARDS. Um, and it is just a multi-organ system shutdown. Your organs start shutting down one by one. Severe trauma is just like multiple fractures. Acute pancreatitis is just a lot of inflammation, which is slowly causing other things to go wrong with infections. Massive transfusion. Some people have um, a really bad reaction to like a transfusion that can later cause ARDS in their care. Drug overdoses or reactions to any kind of medication that can lead to this. And then cardiopulmonary bypass. It's a perfusion injury. Um, Epidemiology, that is the study of how often diseases and health conditions occur in different groups of people. So the incidence, it ranges between 10.1 to 82 people per 100,000 persons per year. The mortality rate is mild, so it's 3.49% if they had a mild ARDS diagnosis. If they had a moderate ARDS diagnosis, it's 40.3, and people with a severe um, ARDS diagnosis, their mortality rate is 46.1. Risk factors are primarily driven by the pneumonia, sepsis, and severe trauma. Pediatric incidents, those affect approximately 3% of pediatric patients in an ICU, and 6% of them end up having to require mechanical ventilation just because their little bodies have taken a toll and they need that extra support to help breathe. And then the demographics, incidents, and like these situations increase the older you are. If you have any kind of comorbidities, any like underlying health issues that can affect your lungs and can eventually lead you to a diagnosis like this. And then clinical manifestations, those are severe dyspnea, which is just, they're struggling to breathe, rapid labored breathing, tachypnea, hypoxemia, cyanosis. Those people, those like their tell signs for that is the patient's fingernails are like either like a grayish blue or their lips. Um, it's just they're not oxygenating, so there's not a lot of oxygen. So their like lips start turning blue. Their skin looks a little grayish. Rapid heart rate, tachycardia. Their heart's trying to work super fast, trying to get as much oxygen. Their lung sounds are crackles and wheezing. Their mental status, they could be very disoriented, confused, like they don't know where they're at. And then chest pain, especially when they like try to take those big deep breaths and they just can't breathe. Um, and then it progresses in stages. So the first like the early stage symptoms for those to look out are severe dyspnea, anxiety, and agitation with rapid progression from dyspnea on exertion to dyspnea at rest. So they're like struggling to breathe when they're trying to move around, but even when they're just kind of like not doing anything, they're still struggling. The late and severe, if not managed right away or caught right away, it leads to severe hypoxemia, multi-system organ failure, which is kind of like where sepsis kind of kicks in, just due to the lack of oxygen, and the need for higher levels of O2 may require mechanical ventilation. So, anatomical alterations of the lungs with ARDS. They have damaged capillary alveolar membrane. The barrier between the tiny air sacs and the surrounding blood capillaries breaks down. There's a lot of alveolar flooding, which is fluid buildup where the swelling comes in. That's referred to as edema. So fluid and blood and inflammatory cells leak into our air sacs, causing intense consolidation. Heavy lungs, which is where all this fluid and all this consolidation just kind of appears in our lungs. It makes our lungs go into like a red and look red, beefy, or a lot of people like describe it as liver-like. Atelectasis. This is where our lungs, our little air sacs, alveoli, they collapse due to all the fluid buildup. It kind of washes away the surfactant, or it destroys the surfactant. So that surfactant is no longer able to help keep our alveoli open so that we're able to oxygenate. So those alveoli collapse. Hyaline membrane formation. Our membrane forms inside of alveoli, acting as a barrier for oxygen exchange. Um, so there's like new membrane kind of keeps forming, it keeps stacking and stacking. So it makes it so much harder for the CO2 and the oxygen to be exchanged and um, moved around. Reduced lung volume, due to the edema and all the fluid buildup, the lungs become severely small, and a lot of people refer to that as a baby lung just because your volume is so much smaller. The fibrosis and the scarring, this is in the later stages. The inflammation leads to like formations of tissue, and then that's what's stiffening our lungs and restricting them in the later stage. And that's what's not allowing us to be able to expand our lungs fully and widely so that we are able to breathe easier. In the next slide. So in this slide, this is kind of like the phases of ARDS. So like in the beginning, there's cell injury, the alveoli barrier, the permeability, the fluid buildup, inflammation. So it's like there's reduced space for gas exchange, breathing difficulties, and then assisted ventilation if needed. So like, our little alveoli is really sad because it's not able to like fully expand and be able to exchange that oxygen. Um, And then here, the fluid, it's slowly starting to go away. So our villi is a little bit, there's still a little bit of exchange, but not too much exchange because there is still fluid, lymphatic drainage of edema fluid, and like there's like breakages around the cell membrane. And this is a fibrotic. So there's fibrosis, there's buildup. So there's not a lot of gas exchanges because that layer right there is so thick. So general management for ARDS, it mostly focuses on supporting oxygenation and minimizing further lung injury. So mechanical ventilation is a big thing that a lot of people go to help these patients recover. It just gives their lungs that break and that time to heal and allow the patient to be able to eventually breathe on their own. The parameters are very low for lung protection, just so that, we don't cause any more damage that they are. So their tidal volumes ranges are from 48 milliliters per kilogram. They do have a PEEP just to kind of give them that added support and keep their lungs open enough for there to be proper gas exchange. Their plateau pressures, we try to keep them under 30 centimeters of water just to kind of not allow that to have any more airway resistance. And then the 5 Ps of ARDS therapy is perfusion. I mean, we want the patient to be able to perfuse properly to do that oxygen um, exchange with the CO2 position. So in the position, that's where we try to give them the max optimal lung capability for them to be able to open their lungs, which is where prone positioning comes. Protective lung ventilation, that is where the low tidal volumes come in, pressure and like low pressure so that we don't cause any more harm. There is a protocol for weaning, and then preventing complications is just trying to keep as much as we can at bay, and just try to keep them as healthy and being able to withstand and come out the other side. So in these images, on image A is a patient without being prone. So this patient was most likely on their back, laying flat with their belly up. And if you can see right here, this is one of their lungs. So there's a lot of fluid. There's a lot of edema. On this one, you can see that this is probably a baby lung just because their volumes are very small. Like you can barely see a lung. And then on image B, this patient has already been proned. So that means they are on their belly with their back up. And as you can tell, their lungs look a lot better. There's more black to it, so there's more oxygenation. And the little lung that is like a baby lung, that one has expanded a lot. There's still some little room right there where there's, I feel like, fluid buildup or something's kind of keeping it from expanding all the way, but there's a lot more air circulating and moving around in there. Okay, so in this video, we talked about ARDS, the anatomic alterations, etiology, epidemiology, clinical manifestations, our management for ARDS. We showed some images on what post-proning and pre-proning can show on our lungs, and then our 5 Ps, and then we will continue.